I'm Cameron McDougall. I'm one of the neurosurgeons at Insight, and I have a particular interest in vascular diseases. And so I thought, we could talk about ischemic stroke. Um, Initially, I was thinking just to go over things that would be of interest to a neurosurgeon who doesn't really do ischemic stroke, but I'm not sure that. I thought maybe we could just talk about the interesting components of ischemic stroke more, and I thought that might be more interesting. So basically, I'll just go over, some of the basic parts of stroke, a little bit of the pathophysiology, but not too much so people don't just fall asleep. And then sort of the development of how we got to where we're at now, which I think is an interesting story. And then I'm going to focus mostly on thrombectomy for this talk because that's what everybody's talking about now, and I think it's what I know the most about. And then the peristroke care, some stuff that may be of interest. If you're working in a hospital and not necessarily doing stroke, and then I have just in a case, but I think stroke is a major problem. I think everybody knows that, but it's big cause of death, major cause of disability. The U.S. is no exception. It's probably worse here because Americans tend to live longer and they're not generally not super healthy. But so you see a massive amount of strokes in the U.S. And then ischemic stroke, the word stroke encompasses hemorrhagic stroke, subarachnoid hemorrhage, and everything. But ischemic stroke is really the lion's share of that. Compared to ICH from hypertension or these kinds of things, ischemic stroke is the big problem in the room. And so addressing it is important and makes a big difference. And it creates stroke, it doesn't always kill. It leads to severe disability in a large group of people, which has significant costs from rehabilitation standpoint, from dependent care standpoint, all these other things. So when I was a medical student, they were always talking about QALYs, which are quality adjusted life years, but now the term du jour is DALYs, which are disability adjusted life years, which takes into account, the number of years you've lost it if you died based on how long you would be expected to live on average, and then the number of years you lived with a severe disability. So it's a huge number in the US, like in 2020. This is a major problem. It's super expensive. Everybody knows that, but it's a big deal. So treatment is important. Just at the cellular level, and again, I won't belabor this too much, but it's kind of, this is the underpinnings of why we treat stroke the way we do. But the way blood flow to the brain is measured is in cc's or milliliters per 100 grams of tissue per minute. So every 100 grams of brain is not quite the same. So the requirements on average are about 50 cc's per 100 grams per minute. But if you just take gray matter, it's closer to 70 or 90 when it's active. If you just take white matter, it's less because it's not doing as much. So it averages out to about 50 cc's per minute per 100 grams. And if you take the average weight of a brain and take this blood flow, it works out to about 20 to 25% of the cardiac output. If you're talking about around 5 or 6 liters of cardiac output per minute. So I sort of like stroke because you don't have to be a genius to understand that if you decrease the blood flow, you get, with the accompanying loss of oxygen delivery, you're going to lose tissue. And so it's just plumbing versus if you look at epilepsy or if you look at DBS, these are complex things with multiple pathways and interaction. Stroke is just, well, it's a plumbing problem. But the amount of blood flow, if you reduce it by a certain degree, there's a time-dependent factor. So the amount of stroke you have is based on how much flow you've lost and for how long you've lost it. If you take average brain tissue, it's probably going to die. If you just cut it off, it's probably going to die within 7 minutes. And that's based on animal studies from primates mostly. So humans are, it's not exactly known, but it's somewhere in that neighborhood. If you just cut off the blood supply. But this is a classic um, classic schematic showing that for nerve tissue, so gray matter, as you get below 50, you start to have cell loss. And it depends again on the amount of time. But if you get down to 30 cc's per minute, um, things start to happen in the cell, and it can recover if you restore flow quickly enough. Down in the 20s and below, these cellular pathways are activated that lead to cell death no matter what. So if you restore the flow, it's still probably going to die because these cellular pathways are activated. That we can talk about clinical applications of how you can try to prevent that a little later on in the talk. But this is, it depends on how low you go. So in this, for gray matter below 50, you're in trouble. But if you restore the flow quickly enough, there's recovery potential within here. Once you get into this range, you're probably not going to be able to recover that tissue. But this is the whole basis for stroke treatment, is this slide, and that there's time to reverse the problem for some of the tissue involved in a stroke. And so that's the idea of a penumbra. And so here, sorry, we have to see everything through instead of the slideshow I sort of planned out, we have to watch it, and it doesn't have the same effect. But here, if you see the vessels occluded, there's a core stroke, and then there's tissue that's getting some blood from collaterals. And if you reverse the flow quickly enough, some of this can be saved. This won't be salvageable. Some of it will just be okay no matter whether you open this or not, and some of it will die. So the farther away you get, the better the tissue does. And here, the whole thing rests on these collateral pathways from other territories. So if you have a right MCA occlusion, you're going to have a core stroke that you can't really do much about, but all this tissue is going to be getting some collateral flow from the ACAs and the PCAs. And the thought is that can keep that tissue alive. There's enough flow, it's in that 50 to 30 range or somewhere in there, where that tissue remains salvageable for a period of time if you open this up quickly enough. And that underpins stroke treatment for the last 50 years. And so the first progress was achieved. This is how we got to where we are today now. So in 1995, the NTDS trial for TPA came out. And this is, as everyone knows, TPA is a massive anticoagulant that will dissolve these clots, or was designed to dissolve these clots. And so if you give TPA within 4.5 hours of a stroke, you can really reduce the disability. So you get a 30% chance of a better outcome at 3 months with TPA. And the number needed to treat, so you need to treat 10 patients to get one good outcome. And that's if you get it within 3 hours. If you go out to between 3 and 4.5 hours, you need more like 20 patients. And after 4.5 hours, the risks of ICH, of having hemorrhagic conversion, go way up, and so the benefit goes down. And so in 1995, everything changed. All of a sudden, strokes, there was something you could do about it if they came in quickly enough, and you could give this TPA if it's within 4.5 hours of their last known well. And so emergency rooms started to organize their strokes, and neurology units started to get telestroke so they could get this drug into people's veins quickly. And from 1995 till 2015, nothing really changed. So it took 20 years to progress from this. And so stroke, it does sort of grow in leaps and bounds, and there can be massive stagnancy in between it. These are hard problems to solve. Everybody, before 2015, ischemic stroke, really neurosurgeons didn't really have much to do with it. It was the domain of stroke neurologists. They would admit the patients. They would give the TPA based on their orders. They would look after the patient's stroke risk reduction. The neurosurgeons would get consulted for the decompression maybe, or for the carotid enderectomy maybe. But beyond that, it wasn't really a neurosurgical disease. There were ongoing trials between 95 and 2015, but they just kept coming up with disappointing results. Everybody knew that if you could open the vessel up quickly, these patients would do better. Just It just had to be the case, but proving it was not easy. And so these trials, two of the more notable ones were the Mercy and the Multi-Mercy trial, where they had these corkscrew devices to take the clots out, and they didn't work so well, and the trials weren't necessarily set up in the best ways, and so they didn't show any benefit. And so even though it made obvious sense that opening this vessel is going to be beneficial to the patient, it wasn't clear cut how to prove that. And it wasn't until stent retriever technology came about a little later that this started to be the case. And so the stent retrievers are a super success story, and it certainly changed what I did. But it was based on stent-assisted coiling. So these stents were used. They started coming out in the mid 2006 and onwards. And these stents would be used if you had a wide-necked aneurysm like this basilar apex aneurysm. The stent could be used to buttress these coils so you could pack the aneurysm and protect it from rupture, but prevent those coils from prolapsing through the neck and occluding these vessels and clot from occluding these parent arteries. So here a stent is laid in the P1 down into the basilar and allows you to coil. And so these stents weren't necessarily designed to be taken out. Once you lay them down, you can't really take them out. But there were some that could be retracted, even if they were only partially deployed. And people realized that, even if you weren't going to use a stent in a different aneurysm, you're packing it, and all of a sudden you lose this vessel from a little bit of clot, particularly after subarachnoid hemorrhage. Those patients tend to be hyperthrombotic. People realized that a stent was a nice bailout. You could lay down a stent, it would keep this vessel open, even if it was just some clot right here. The stent would open it up. And then somebody smart recognized that this vessel is occluded. They laid down a stent without fully deploying it, pulled it back, and realized they could pull the clot out and not have to leave a stent, presumably while you're getting some kind of medication on board with the patient to prevent further clotting. But that's what led to stent retrievers. So stent retrievers are based on these stents, but they're not quite the same. This slide doesn't look as well, but the trials that were designed around stent retrievers started coming out January 1st, 2015. This was the first trial. That was the Mr. Clean study, a Dutch study where they showed that there was a massive benefit if you did this thrombectomy within 6 hours of the onset of symptoms. This was the ESCAPE trial, which was based in Alberta, and my center was where I did my residency. We were part of it. I remember randomizing these patients or watching them get randomized, and it ended up having a massive benefit. And there were 3 other studies, all that came out in 2015. So 5 major studies in major journals that all showed that thrombectomy is a really valuable tool. And I'll just show you. This is one way to do a thrombectomy. This is a little video here. This is how I like to do it. We used to call it the kitchen sink because it involves all of the technology. This is from a company, Stryker. It's one way to do it. There's many ways to skin a cat, but if you have a clot coming up, it gets lodged in the middle cerebral artery. There's no flow on the angiogram here. What you want to do, one way to do this is you're going to get this is just a picture of the stent retriever. So it gets loaded through a microcatheter, and as you pull the microcatheter back, the stent retriever is allowed to open. And so the idea is it captures the clot. So you get your groin access, and you'll have a balloon guide in the neck, and then an intermediate catheter through the balloon guide, and then a microcatheter and microwire. And so you use your microcatheter to get up into the head under X-ray guidance. The microwire is used to cross the clot here, which is a little bit dicey because you can't really see where you're going. So you advance your microwire up to the clot, and then after the clot, it's a bit blind. Then the microcatheter will follow the wire, and then you're going to pull the wire out. I'll usually do a run after that just to confirm I'm still in the vessel. I haven't done something terrible. Then the stent is advanced through the microwire. The intermediate catheter is brought up. And then you're going to unsheath this just by pinning the wire attached to the stent and pulling back the catheter. You unsheath it, and it springs open across the clot. You can see they're opening it here. And now your stent is in place, and you give it, typically you want to give it 5 minutes that's the cookbook answer. Some people do it a little quicker. This is what it looks like under fluoro, but you start a physical timer and count 5 minutes and let the clot kind of insist into the tines of the stent. And so after 5 minutes, you're getting ready to pull. So you'll inflate your balloon guide, which is in the internal carotid in the neck, to stop flow. So there's no flow coming up now. And you pull your microcatheter back so that this tube can suck more aggressively, and it's hooked up to a balloon or to a pump that's going to suck. And so now this is sucking through here. You're pulling all the blood back, and you advance this intermediate catheter right to the clot interface. So you'll just advance this over until you get it grabbed, and you're right at the clot. And now you've got a good grasp on this thing, and you're sucking from here, and this is grabbing, and you pull the whole thing out through the neck down into that balloon guide. And then remember, flow's not coming forward because the balloon is occluding it. So now you pull the whole thing out, and you're bringing all the chunks with you, and then you suck back to this balloon. So now you can deflate the balloon, flow will go forward. You suck back through the balloon to make sure you get any clots out with it. And then you'll do a run, and hopefully you've got it open. And if you get it open on the first pass, that's always nice. And so this is, again, there's a couple of ways to do this, but this is the way I prefer, and it works a large amount of the time. You get this open on the first try, which is always satisfying. If it doesn't work, you have to go up and try again. You can usually try a couple of times, and then you have to think of something else to do. But the numbers needed to treat, though, for thrombectomy are extremely impressive. So if you look at TPA thrombolysis, so again, as I said, if you treat within 3 hours, you need to treat 10 patients to get one beneficial outcome. If you go 3 to 4.5 hours, you need to treat 20 patients. If you are having a ST elevation MI, you know, chest pain, grasping the chest, lights and sirens, you show up in the emergency room. If they're going to do a percutaneous coronary intervention, so where they do an angioplasty and stenting in your heart when you're having a heart attack, they still need to treat 16 patients to prevent 1 death or recurrent heart attack. So 16 for a major heart attack, you know, many people don't realize that those, I mean, it's still a good number, but, and if you're having a non-ST elevation MI, so electrocardiographically, you're not really having a heart attack, but you know, your troponins are elevated and they do open the vessel, they need to treat 91 patients to have a good outcome or prevent a recurrent heart attack. And so the cardiologist built an empire on these numbers. Emergency rooms, everything was set up, organized to get patients to a cath lab so they could do these procedures for these numbers. For thrombectomy, based on the study inclusion criteria, you need to treat just under 3 people to have a good outcome. So if you treat 3 people, somebody's going to walk out the door who was otherwise headed to a nursing home or to the morgue. So these numbers are phenomenal. Thrombectomy is a massive benefit to these patients if they qualify for it. So then the question becomes, well, who's going to benefit? How do we select these patients for this treatment? And so that you need to assess the tissue somehow. And this was also a developmental story. So it started with this Alberta stroke protocol CT score, where we would look at their CAT scan, and everybody starts off with 10 points, and you look at 10 different areas, and you subtract a point for every area that's looks like it has a stroke in it. And so if they got below 6, we usually wouldn't do it. And if they were above 6, it meant there was enough tissue to save that we would do the thrombectomy. The collateral score also was tacked onto that later on. So you look at their CTA and see how much blood is getting there from other sources. And if there was a scoring system, and that led you to surmise that there was tissues to save there. MRI is the gold standard, but it's a time waster. You usually don't have time to get an MRI for these patients, except in research settings, or there's a few centers that will have a dedicated stroke MRI with a team in-house, and they can do it quickly. But generally, you don't want to mess around with MRI unless it's for research. So CT perfusion has become the workhorse here, and the software is added to any CT scanner. These patients already get a CAT scan, they already get a CTA, and the perfusion is just added to that. So there's no extra investigation for perfusion, and it's quite nice. So these are the images you'll get. This is a guy with new onset aphasia. He doesn't appear to have a left-sided stroke here, so his aspect score would be good, but you don't really know if that tissue is going to be salvageable. But on the perfusion, what you have here, this area shows decreased blood flow. So he's not getting as much flow on the left side here. There's something wrong. And here's the blood volume. The volume isn't that much different than the other side. So the volume is preserved, suggesting that tissue is still, once the volume goes down below a certain threshold, you can surmise that there's a stroke there. But if the volume is preserved or elevated, that tissue is, it will sometimes elevate because of autoregulation. The vessels dilate in response to decreased oxygen tension. And so the volume, if it's up or normal, you can say, well, that tissue is not getting as much flow as it needs, but it's still alive. And this is the transit time of the contrast. So it's taking longer to get here than compared to the other side. And so you can say that this is getting fed by collaterals probably. And this is what we would call a mismatch between flow and volume. And that means that there's a penumbra there to save if there's a mismatch. And so your phone, you'll get a text with this information on it, and the computer will spit out a number and tell you how big the penumbra is in milliliters, and you'll know, okay, well, get the cath lab organized and we'll take this patient there, and I'll be in a few minutes. And so it's a very nice technology, and it's just standard software that can be added to any reasonable CT scanner. And so this is the way that things have gone in terms of selecting these patients. But what you don't want to do, and this was pointed out by a guy named McDougall in Calgary, he called it the fallacy of the denominator. And so you don't want to be too much of a gatekeeper with this procedure. This is supposed to be a tale of two cities. And again, it's this guy who is the designer of the ESCAPE trial who came up with this example. But if you have two cities who are otherwise identical and they both have 200 strokes in a year, and city A has guys who just do the thrombectomy, they just take the clots out and see what happens. And so they end up doing 120 thrombectomies out of 200 patients, and they have 60 good outcomes. So 60 out of 120, they're ending up with 50% is their outcome rate, rate of good outcomes. It doesn't, this is all theoretical, but city B has the same stroke population, but these guys are academics, and they only do thrombectomies in patients that are for sure going to benefit. They're very selective. And so they end up doing 20 thrombectomies and they have 18 good outcomes. So they have a 90% rate of good outcomes with their procedure, which is impressive. But then when you think about it from a societal point of view, there were 42, there's a difference between the two of good outcomes because city A was more inclusive in who they did a thrombectomy for. And so these are, there's 42 extra patients who are not filling up nursing homes in this example, who are not in the cemeteries. So this is a major difference. And so from a societal standpoint, you're better off just doing the thrombectomy. And my policy was just if in doubt, suck it out. And so I think this sort of idea backs it up, particularly within 6 hours. So then people started to organize stroke centers so that more people would get thrombectomies and organize EMS and everything. And so this was an initiative from a guy in Arizona, a neurologist, but if they use this van policy where if the patient has visual problems like hemifield defect, hemianopsia, any aphasia, or any neglect, that's likely to be a large vessel occlusion, and those patients are likely to benefit from a thrombectomy. So the idea of identifying these patients early on, and mathematically they sort of looked at this, and so if the patient has any of these features, they should just bypass the primary stroke centers that can only give TPA and go straight to the thrombectomy capable stroke centers. And so this was passed through EMS and through the emergency room doctors. And so the emergency room doctor will get a call and the EMS guy will evaluate the patient for these things. And if he checks any of these boxes, they go straight to a place where they can do the thrombectomy as opposed to stopping and wasting time to get the TPA at a primary center because they're going to have to do an evaluation and everything. It's just going to take away time, and the patient is going to end up losing brain tissue as a result. And so societies, stroke centers are trying to organize things in a way that gets more patient thrombectomies. So then the next stage came with these two trials in 2018. the Dawn trial and the Diffuse trial, which were sort of industry-sponsored trials, but they looked at doing a thrombectomy after 6 hours, between 6 and 24. And this is a major issue in stroke because a lot of people wake up with new problems, and you have to, they're weak when they wake up with new left-sided weakness, and you have to go, you have to assume that the stroke started when they were last seen well, or patients who are aphasic and can't communicate when their stroke started, you have to go by when they were last seen well. And so those patients always get excluded from these studies and from this therapy. But these studies looked at patients who were within 6 to 24 hours after the onset of stroke. And it turns out if you're selective, so here they were using MRI to decide who had a penumbra and who didn't. But if you're selective, if you pick patients who have a penumbra, the number needed to treat is still like 2 or 3. So if you're treating these patients and selecting them carefully, you just need to treat 3 patients to get one really good outcome and save a patient from a nursing home or from a dependent living facility or from the cemetery. And so this really changed things in terms of timing of stroke. And so for me, I really don't, sometimes emergency doctors will say, well, this happened 30 hours ago. There's no point in calling the neurosurgeon about doing a thrombectomy. But for me, I really don't care about how long ago this happened. I want to see if there's a penumbra there or not, and I will consider doing the case. I'm certainly more selective after 6 hours or after some period of time. I'm more selective about who I'll do it in, but that doesn't mean that I'm writing the patient off. And I always think about a case I saw when I was a fellow of a 22-year-old girl, and her boyfriend noticed that she was not moving one side of her body, and he put her to bed and watched her the next day. She wasn't any better, and finally, at the end of the next day, he brought her into the hospital and said, something's wrong with her, and she was, totally hemiplegic, massive stroke, symptoms. But she was like 48 hours out from when she had last been seen well. And so the neurologist admitted her, they did an MRI and they realized there was a big penumbra there. So they called us and said, would you guys take this clot out? What do you think? So we took the clot out, and this young lady, it turned out she had a thrombophilia, like a antithrombin 3 deficiency. So she formed clots more easily. And so that was the reason for her. That's why she had the stroke. But this young girl, 22 years old, walked out of the hospital 4 days later on anticoagulation, like literally walked out. And, she was headed for nothing good. And at 22, that's a long time in the nursing home if she survives, So you can't write these people off just based on what the timing shows, what the clock shows. You have to really evaluate it. That's an extreme example. The farther out you get, the less likely that any tissue is going to survive. But the point is that you really have to not pretend that these are hard cutoffs, that at 24 hours, then magically everything's dead, because even at 30 hours, there's some patients with excellent collaterals, and they're going to keep that tissue alive. And so you just keep you just need to verify that these patients aren't candidates for thrombectomy. In terms of the future, I think this was a study by a guy named Mike Timiansky, and I spent one summer as a medical student in his lab when he was working on this drug called narinitide. And basically what it does is it's a neuronal nitric oxide synthase inhibitor. So it inhibits that cellular cascade that gets activated when the blood flow gets low, or that's the idea. And so it prevents that cascade from activating cell death. So the idea would be that these patients get this drug either from EMS, or as soon as they hit the ER, they get this drug injected intravenously, and then they proceed with their regular stroke workup to open the vessel. But this drug helps keep that tissue alive a little bit longer. And so in long transports and things like that, this could make a real difference. This study is from 2020. It did not show efficacy of the drug. The thought is that it was in patients who got TPA and the drug, they did not benefit. But patients who didn't get TPA, had a thrombectomy, and got the drug did better than patients who just had a thrombectomy. So, There may be some interaction between this drug and TPA. It's not known. I do think there's probably some effect there, but even if there's not, this is probably the future, these neuroprotectants, and this will probably save brain tissue. And if this drug doesn't work, the next one will. This is the path forward, I think. And it may take 20 years before it becomes the thing to do, but it will come, I think. I think that's where this is headed. Other things, peri-stroke care stuff, the carotid endarterectomy. So these patients, if you're doing a thrombectomy in someone like this, you see this gruddy, this stenosis, an ugly plaque there. This is a patient, you'll cross this plaque to do the thrombectomy, and then the instinct is to just stent it on the way out. And I know many people who do that. This is controversial. I personally will not, because I've been burned, and you put the stent down and you commit the patient to aspirin and Plavix. You can't take the stent out again, of course, and then they have hemorrhagic transformation of their stroke, and you've already committed them to aspirin and Plavix, so you're stuck. I've been burned a couple of times. So now I'll just pull my catheters back across, and if it stays open, I won't stent it, and I'll come back even on the same hospital admission or maybe a week or two later and either do an endarterectomy or a thrombectomy, or endarterectomy or a stent based on what I think is the best approach for that patient. So just stenting everyone in a thrombectomy situation, I don't think is the right approach, but that's controversial. That's my opinion. That's not settled, but that's how I do it. But if you get called for an endarterectomy after a thrombectomy, you might ask, well, why didn't you just stent it? But that's the reason. It's not always the best thing to do. Something that's pretty common is decompressive hemicranies for big strokes. When I was a resident, I thought this was probably not great because you're just sending these patients to nursing homes with massive deficits when they could, you could just let them die with some dignity by not doing the surgery. And I obviously don't do that, but I think in this scenario, I think it's a personal choice based on what the patient would have wanted when you consult with their family. For me personally, I would not want a hemicraniectomy on my left hemisphere. This person's going to be aphasic. They're going to be hemiplegic. They're going to have a hemifield defect in visual field wise. And I personally, if I come into Hurley this weekend and my scan looks like this, please don't do anything for me. But I think you can consult with the family and see what they want to do. And I think if you individualize it, many patients will choose to do the surgery. You're basically trading life for disability, severe disability. But this was a big study, or a nice study from 2020, where they reviewed all the studies that are out there, a meta-analysis, and basically they found that indeed all of these patients end up pretty severely disabled. But if you evaluate them from a quality of life standpoint, a big chunk of these patients and their families and their caregivers say that their life is worthwhile even after this was done. So they're not necessarily unhappy and disabled. So I think you have to individualize this treatment based on what the patient would have wanted. An older patient who comes from a nursing home, it's probably not the right thing. A younger patient, with a supportive family, it may be the exact right thing. So again, I think individualization is the key with decompressive hemicrania, and you talk to the family, and generally you have time, but sometimes they don't call you till it's late and the patient's blown a pupil, and then your hand is forced. But if you have the time, and this is one of the advantages of being a neurosurgeon involved in the thrombectomy, I can say, well, this patient, we couldn't get it open, or we got it open, but it's too late. They're going to have a stroke. So I'm talking to the family about the hemicrania before I even know if the patient needs it or not, so that I can just come in the middle of the night and just do it without having to think about it too much. I'll just show you my contribution to the stroke literature, which is very insignificant, but it was based on an interesting observation that I saw in a patient. This was a patient in Texas. They're very simple about how they name places. And so in the eastern Texas, on the border of Texas and Arkansas, you have Texarkana. And in northern Texas, on the border with Oklahoma, you have Texoma. And then on the western border with New Mexico, you can guess what the name is. That's where Texaco is located. So they always have these funny names for places which are exactly where you think they're going to be. Anyway, I got a call about an 83-year-old lady with big, good stroke, weak on the left. She's got a clot in her right MCA. She's got pretty good deficit. So they gave her TPA and shipped her to me by air transport. So she shows up in my emergency room and I evaluate her, and she's actually perfect. Her stroke scale score is 0, so she has no deficits. And so as part of my protocol, everybody gets a CTA. So I did the CTA, and you can see here on the left, you see here we are, the carotid's wide open on the left. There's the MCA going out. And then on the right, here, this is the A1 filling across, but there's no carotid artery, no MCA. There's nice collateral. That's why she's filling most of this hemisphere from collateral flow, and she's able to tolerate that. And so her carotid is still occluded. And so I didn't know what to do. This was controversial at the time. And so in an 83-year-old lady, I said, well, I'd rather not do anything. We'll just watch her closely. And so even though I know that vessel's still blocked, she seems to be tolerating it. So why take some risk with the procedure? And I watched her, and then I got a call from the resident at 6:48 in the morning. And the resident said, this lady has major deficits. She's really weak on the left. And so I immediately assumed that she had hemorrhaged into her stroke. And because she had gotten TPA, I assumed she had a small stroke and hemorrhaged into it. And so we got a stat CT head, there's no stroke, or there's no hemorrhage, pardon me. And so she already had an MRI teed up, and the team was there. So I said, well, let's do a quick MRI. Maybe she just had a big stroke overnight, and it wasn't recognized, and the resident came in and did a proper exam, and maybe they just weren't looking after her as closely as they should have been. So I did the MRI, even though it wasted a little bit of time, but she hasn't had a big right-sided stroke. So I took her to the cath lab, and the carotid was still occluded. Here you can see this is a right carotid injection here, common carotid actually. And the carotid is just ending right there. This is the PCA and PCOM coming up on, this is the AP view. And on the lateral view, you see here, there, her carotid just ends. That's PCOM going back to the PCA territory. There's nothing getting up here, ophthalmic here, but this carotid is occluded. So I opened it up, did a thrombectomy, opened it up, got a nice result. This is the AP view afterwards. So all this MCA flow is going out. And this lady did fine, but my point was, and I ended up calling people who had seen the same thing, and we put our cases together and decided that you're better off just doing the thrombectomy if these patients come in and they're better, because if the vessel's still occluded, they're probably the odds are their collateral system is going to crap out sooner or later, and they're going to deteriorate clinically. And, this lady was really lucky that it happened when it did. It can happen at 4 a.m. and the team doesn't come in and these other things, or you send them home. Worse yet, they go home and then they deteriorate, and then it's going to be a gamble as to whether you can get it open or not in time to save that brain. So rather than press the luck of the situation, I wrote a paper that said that you should probably take out the clot right when you see it. And I think that most people will do that now, though it's not, it wasn't a definitive study. This is pretty rare to see that, but that was my own personal minor contribution, and nobody cares, but that I just thought I'd share that. That's sort of all I wanted to say. I don't really have much else. This was this picture was a picture I went to Australia in 2019, and I was renting a house on the Mornington Peninsula outside of, not too far, a couple hours away from Melbourne. And in the rental house, I woke up in the morning and this guy was crawling on the fence. And he was just looking, and he was super curious. I just left him alone, but it was pretty neat. You don't get to see them very often. So I was I took a picture and it stuck with me. Anyway, that's really all I had to say. I mean, I'm happy to entertain any questions if you have any, but hopefully that gives you an idea of how stroke got to where it is and what the sort of standards are now. It's not meant to be comprehensive, but if anybody has comments or questions, I'm happy to
I do see
respond.
one question on there, Dr. McDougall, about
Yes.
how big is a blood clot from Samantha Freeman?
It kind of looks like, it ranges. Sometimes you end up sucking it out into that pump, and so you don't get to see it. But if it gets stuck if it gets stuck in the stent retriever, you can see this is a clot here. It kind of looks like a giant booger. And this is, maybe the size of the tip of your pinky or something. It's not huge. It doesn't take much to block these arteries. They're usually, on average, the MCA is about 3 millimeters in diameter, so it doesn't take much. You can have big, long ones too sometimes, but this is, I would say, pretty typical of what it looks like. You pull out the stent and it's stuck in there, and you don't get perspective here, but these stents aren't very big, so it's not a huge amount.
All right, that's the only question I see in there.
No other questions? Well, that's okay. If anybody else wants to talk to me about this, I'm always available. But it's not something that we do every day at Insight. But I think it's still interesting to some people.
Absolutely.
Okay. Well, I guess we'll leave it there.
All right. Thank you so much, Dr. McDougall, and everybody else as well.
Thanks, everybody. I hope you all have a good day.